as a normal patient. So no, excessive gas is not the factor here. The first mechanism is the visceral hypersensitivity. These patients perceive normal physiological bowel activity as uncomfortable and painful. Second is delayed colonic transit, where retained stool will increase the fermentation that will lead to formation of carbon dioxide, methane gases and contribute to the sensation of fullness. The third is the gut dysbiosis, and fourth, which is again an emerging and a very recent concept, abdomino-phrenic dyssynergia. We will be talking about that in the next slide. So my key message here is gas often is the passenger where the driver is an altered physiology. The shift in understanding how we evaluate, treat bloating will instead of repeatedly prescribing the anti-gas medications, we begin to ask what underlying mechanism is responsible. So talking about the APD is one of the most exciting development in understanding the chronic bloating. Normally what happens when you have meals, the diaphragm will relax slightly and your abdominal core muscles will contract. It will try to accommodate the abdominal contents without visible distension. In APD, this coordinated response is reversed. Here, the diaphragm is contracting and descending down, and at the same time, the abdominal muscles are relaxing. So, the patient feels that the abdomen is relaxed and it is protruding. The very common symptom is I wake up with a flat abdomen, but by evening, I look like a pregnant lady. So, this is not in their head. APD is a very recognized and a proven mechanism behind this. For people or patients suffering from APD, again, your anti-flatulent medications or anti-gas medications are not going to work. They will require physiotherapy, breathing exercises, and targeting the core muscles along with the gut-brain axis. Now, the next step is to evaluate patients systematically rather than just giving them treatment empirically. So, a structured evaluation begins with 5 simple questions. Is the transit delayed? No. If not, if evacuation is impaired, could this be a disease of gut-brain interaction? Could there be a structural disease, or is there a chronic constipation due to medication or systemic illness? The questions immediately guide further evaluation. Begin with the detailed history, then go to the Rome 4 criteria. I have attached the Rome 4 criteria in my appendix last slide. And then you can characterize the stool consistency with the Bristol stool scale. The digital rectal examination remains one of the most valuable underutilized part of the assessment. Alarming features such as rectal bleeding, iron deficiency anemia, unexplained weight loss, nocturnal symptoms do warrant a colonoscopic evaluation. The most important slide for this session, after identifying the mechanism, the treatment becomes much more logical. The era of prescribing the same laxative to every patient is over. Management should always begin with lifestyle modification, adequate hydration, regular physical activity, individualized fiber intake that we all know that we keep prescribing, but that should still be your first line treatment. After that, the Mediterranean diet has emerging evidence for improving the gut microbial diversity, and the practical algorithm for your OPD can be for mild constipation, you can prescribe lifestyle modification with individualized fibers. For chronic functional constipation, polyethylene glycol, which is an osmotic laxative, still remains the first line and has very strong evidence in multi-research analysis. For hard, painful stools like fissures or hemorrhoids, short-term cremafin and another stool softening approach. For dyssynergic defecation, go for biofeedback, not escalating laxatives. And for slow transit constipation, refractory to standard therapy, consider prucalopride or secretagogues depending on availability and patient factors. The paradigm shift here is constipation is now not viewed as a simple problem of inadequate fiber or poor hydration. The treatment pathway, which was predictable, is now abandoned. We consider constipation represents multiple distinct disorders, and instead of asking which laxative should I prescribe, we first ask what phenotype of constipation does the patient have, and then we go forward to prescribing the treatments. So there are certain patients who will deserve a second look. These are the women who return despite trying multiple laxatives. They describe incomplete evacuation, excessive straining, or the need for digital assistance. Women with persistent obstructed defecation or those with rectal bleeding. Please think if the patient has any internal rectal prolapse or a symptomatic rectocele or an SRUS, or very importantly, an underlying colorectal neoplasm. The message I want you to remember is the symptom is constipation, the diagnosis might not be. I'm just finishing up. Last and very important, the clinical pulse. Persistent constipation despite optimal therapy is where a patient might require advanced evaluation and where a multidisciplinary collaboration may help. Need for digital evacuation, obstructed defecation, alarming symptoms, suspected functional anorectal disorder, or a suspected structural or outlet obstruction such as hemorrhoids or anal stenosis, or an ODS. Early multidisciplinary care will always help. These are my take home messages. I will be very happy if tomorrow one of your consultation will start with not which laxative should I prescribe, but why is this woman constipated? So constipation is a syndrome, not a diagnosis. Bloating is rarely caused by excessive gas alone. Menopause remodels bowel physiology through hormonal, microbial, and neuronal pathways. Treat the underlying mechanism, not merely the symptom, and precision medicine and multidisciplinary collaboration will represent the future. I leave this slide to you so it helps you for your OPDs. Thank you very much. And if any questions, I'll be happy to take them.
Thank you. Thank you, Dr. Zeel. It was a wonderful presentation. You have crystal clearly explained the various types of constipation and
Yes.
bloating. Actually, it is a very unseen topic to our
Exactly.
fields. We give blanket therapy like
Yes.
laxatives and anti
Yeah.
flatulence and all.
Yes.
So it was a wonderful presentation. Definitely, it will add on in our practice from tomorrow onwards.
Thank
So
you
we
very
have to
much.
treat the phenotype, not the
Exactly.
symptoms only.
Yeah.
So thank you. It
Exactly.
was a wonderful presentation.
Thank you.